From the JAMA Network, this is JAMA Clinical Reviews, interviews and ideas about innovations in medicine, science, and clinical practice.
Hello, and welcome to our listeners around the world. You're listening to the JAMA Clinical Reviews podcast. Thank you for being here. I am Dr. David Simel, JAMA Associate Editor and Professor Emeritus of Medicine at the Durham Veterans Affairs Medical Center and Duke University. In this podcast, we will be discussing patent foramen ovale, which I will refer to as PFO, and stroke. I'm joined today by Dr. David Kent, who is Professor of Medicine and Neurology at Tufts University. Dr. Kent is the lead author of our narrative review on PFO and stroke, which appears in the July 28, 2025 edition of JAMA. Dr. Kent, thank you for joining us today.
Thank you so much for having me.
Well, before we dive right into a discussion about PFO, I'd like to discuss the basic evaluation of a patient with stroke to determine the etiology and what we mean by the term cryptogenic stroke.
Well, cryptogenic stroke is basically a fancy term for wastebasket category of a stroke without a clearly defined cause, even after comprehensive workup. So there are dozens of different causes of stroke. So there are many, many tests that we often do, but I like to think of four basic categories of tests to diagnose the main causes of ischemic stroke. The first test that we often get is just a neuroimage, either a CAT scan or an MRI, and this will typically visualize the infarct. And just from visualization of the infarct, we can get a clue as to the cause of the stroke. So if, for example, we see a 1 centimeter subcortical stroke in a patient with diabetes and hypertension, we'll call it a lacuna stroke and we'll attribute the mechanism to small vessel disease. The next test we do is something to visualize the large vessels of the head and neck, and this will be done by an angiogram, either a CT angiogram, an MR angiogram, or even just carotid Dopplers. And here, if we see a stenotic large vessel, for example, a tight stenosis of one of the carotid arteries ipsilateral to the stroke, then we can often attribute the stroke to large vessel disease. The next test we get on all patients is an electrocardiogram of some sort, either just a 12-lead EKG as they come into the emergency room, or when we admit them to the hospital, we'll typically put them on telemetry for their stay. And sometimes either of these tests will pick up atrial fibrillation, and if we find atrial fibrillation within their hospitalization, we'll attribute the mechanism to a cardioembolic stroke from the atrial fibrillation. And finally, we also get a cardiac echo. Most often, this is a transthoracic cardiac echo that helps us visualize the left side of the heart, the left atrium, the left ventricle, and the valves, which can be, again, a source if there's any thrombus in the atrium or ventricles or on the valves from some valvulopathy, then that could also be a source of a cardioembolic stroke. Now, it's important that we identify the cause of the stroke because the treatments for each of these strokes is different.
Well, let me ask two follow-up questions about the workup, and the first is about cranial imaging. You mentioned CT scanning and MRI scanning. Do all patients require both a CT, an MRI, and then a CT angiogram and an MRI angiogram?
No, you don't have to get both a CT and an MRI. If you visualize the infarct on a CT, the MRI may not be necessary, and you could also use the CT scan to get a CT angiogram to visualize the large vessels. Often patients will get both. Sometimes when patients come in with an acute stroke, for example, the stroke might not be visible on a CT scan, and they'll sometimes get a follow-up MRI to better visualize the stroke.
And the second follow-up question has to do with the electrocardiographic monitoring, because you mentioned atrial fibrillation, which seems like it could be particularly vexing since patients may not have persistent atrial fibrillation. Are there any guideline recommendations for prolonged ambulatory monitoring to decide whether or not a patient has atrial fibrillation?
Yeah, so if a patient has a stroke and there's no other obvious cause of the stroke, and atrial fibrillation is not found during the hospitalization, Guidelines typically recommend long-term monitoring for at least 6 months or even longer. But the question in PFO-associated stroke is a little bit different because we do have a potential cause of the stroke. And the question is, how long do you have to monitor the patient before you're able to attribute the stroke that you see to the PFO? And here the guidelines differ tremendously. The American Heart Association recommends that you monitor the patient for atrial fibrillation for at least 24 hours, whereas the European guideline recommends up to 6 months of monitoring. And the reason why the guidelines differ so much is that the evidence base is not so good to establish the optimal duration of monitoring. It's true that the longer you monitor patients after stroke, the more atrial fibrillation you will find. But it's also true that the longer you monitor patients for potential atrial fibrillation, the less confident you might be that when you find the atrial fibrillation, it's actually the cause of the stroke instead of the PFO.
Well, that's a nice segue into a more in-depth discussion about the PFO-associated strokes. So let's review what the foramen ovale does during prenatal development and then what happens after birth.
So the foramen ovale is part of a set of structures in the fetal circulation that permit oxygenated blood from the placenta to bypass the fetal lungs, which are non-functioning, and gain access to the systemic arterial circulation in the fetus and thus oxygenate the fetal tissues. It's formed by two membranes, the septum primum and the septum secundum. After birth, the pressure in the left atrium goes up very high because of the blood flow to the lung, and this presses the two membranes together, causing them to fuse and closing the shunt. Over the first year, the foramen ovale seals in most people, but in some people, it doesn't seal completely, leaving a patent foramen ovale.
How often does that happen? And in the absence of a stroke, just in the general population, is there a way to predict who might have a PFO?
Well, it's surprisingly common. In the general adult population, we'll find PFO in approximately 25% of people. And there's no way to predict who has a PFO and who doesn't have a PFO. It seems to be distributed randomly in the population. And it's generally of no clinical consequence because the amount of shunting you get is relatively small and not hemodynamically significant.
If I could actually look at a PFO, what would I see? Is it just a hole between the two chambers?
No. Well, if you look at the atrial septum, you'll just see the septum, and then barely visible might be a tunnel-like structure, which is the PFO. It tends to be maybe on average a little less than half a centimeter and maybe on average a little less than 1 centimeter in length.
Now, you said an echocardiogram is part of the standard workup. Does my typical transthoracic echocardiogram detect a PFO?
A transthoracic echo can detect the PFO. So you could see if a PFO is large enough, you could actually see it, the structure of a PFO on a transthoracic echo. But in the setting of a stroke, if you don't see it on a regular plain echo, you really need to do other tests to look for it because a transthoracic echo is very insensitive. First, you would need to do a bubble study, and a bubble study can be done with a transthoracic echo. And that is, you inject agitated saline into a vein in the patient, and you visualize the left atrium of the heart. And what you're looking for is first opacification of the right atrium with the echo-dense microbubbles from the agitated saline. And if in 3 cardiac cycles, any of those microbubbles transit across the atrial septum into the left atrium, then that is potentially abnormal. Now, in the setting of an otherwise cryptogenic stroke, if you do a transthoracic echo and a bubble study and you don't see it, there are other more sensitive tests that you really need to do to rule it out with a higher degree of confidence. And the 2 tests we often do, one is a transcranial Doppler, which basically detects microbubbles within the cerebral circulation. That's very sensitive. And then the other test, which is often the preferred test, is a transesophageal echo. In that test, the echocardiographic probe is introduced into the esophagus to get a closer look at the structures of the heart and at the interatrial septum. Now, the reason the transesophageal echo is preferred, with a bubble study, by the way, it's more sensitive in detecting the PFO than the transthoracic echo. But the other reason it's preferred is it also permits detection of other structures around the heart that might be implicated in the stroke. It permits you to grade the PFO. Is it a large PFO? Is it a small PFO? And finally, it allows you also to visualize whether or not the patient has an atrial septal aneurysm. And the presence of an atrial septal aneurysm is associated with a higher risk PFO.
So how is the PFO itself associated with the stroke?
So the association arises through a mechanism we call paradoxical embolism. And the embolism is called paradoxical because a stroke is typically caused by an arterial blockage, an arterial clot. But a paradoxical embolism arises from a clot in the venous system. And the embolus comes off and it gains access to the arterial circulation through a right to left shunt, in this case through a PFO, the most common cause of a right to left shunt.
So we have an obvious problem here because you described PFOs as being very common and ischemic strokes are very common. So how do we know when the PFO is actually the cause or led to the ischemic stroke?
Yeah, well, that's a very good question, David, and it's something that's preoccupied us for maybe the last 2 decades. So we've devised a couple of different scoring systems. One is called the ROPE score, and another we've called Pascal. The ROPE score, basically ROPE stands for risk of paradoxical embolism, and that score predicts the probability of finding a PFO in a patient with an otherwise cryptogenic stroke. And the idea there is that we can use that probability together with Bayes' theorem, as it's described in the article, and estimate the probability that the PFO is the cause of the stroke. So, for example, in older patients with an otherwise cryptogenic stroke with multiple vascular risk factors, so let's say we have a 60 or 70-year-old person with hypertension, diabetes, smoking, hyperlipidemia, the prevalence of a PFO might only be around 25%, which is roughly the same as the general population. So if we find a PFO in a patient like that, it's very, very likely that that's just an incidental finding, and it's very unlikely that that's pathogenically related to the stroke. In contrast, in a young patient with cryptogenic stroke, say a patient in their 20s or 30s or even 40s, without any of these vascular risk factors, no hypertension, no diabetes, no smoking, the prevalence of PFO in a patient like that might be as high as 70 or 80%. And therefore, if we find the PFO, given the fact that the contrast between that and the 25% in the general population, we can be pretty confident that the PFO is the cause of the stroke in such a patient. Now, the ROPE score is not perfect. It's not totally comprehensive. The one thing that it doesn't include is any of the anatomic or physiologic features of the PFO itself. So for this reason, we developed something called the Pascal classification system. Pascal stands for PFO-associated stroke causal likelihood classification system. And that stratifies patients into 3 categories: unlikely, possible, and probable, based partly on the ROPE score and also on characteristics of the PFO, in particular, how large the PFO is. So a large PFO is much more likely to be pathogenically related to this stroke than a small PFO. And a PFO with an atrial septal aneurysm is also more likely to be pathogenically associated with a stroke than one without. So Pascal incorporates all the characteristics we just spoke about in order to estimate the overall probability that the stroke can be attributed to the PFO.
So to summarize the Rogue score, if you've got a lot of traditional risk factors for an ischemic stroke, you're more likely to have had an ischemic stroke even if you have a PFO. And the fewer risk factors you have for an ischemic stroke, the more likely it is that the PFO was causal.
That's exactly right. In the presence of many other vascular risk factors, there are many other occult potential causes of an ischemic stroke than the absence. So
it sounds complicated enough that you ought to have a neurologist and a cardiologist involved in your assessment of the patient with cryptogenic stroke and the consideration of whether or not a PFO was associated with that stroke.
That's absolutely true. It's especially true if you're considering a patient for closure. In all the 6 trials combined, they showed that closure was very efficacious in preventing a recurrent stroke. Within all those trials, there was close collaboration of the cardiology team with the stroke neurology team in order to select the patients that went in the trials and for closure.
Tell me what you mean by closure.
So, closure is really the therapy that's recommended to prevent recurrent stroke in well-selected people with PFO-associated stroke. It reduces the risk of a recurrent stroke by maybe around 60% on average within the trials. Closure is achieved by percutaneously introducing a device, typically into the femoral vein, and introducing it up into the right atrium across the PFO and into the left atrium, and then deploying the device such that the PFO is closed.
What about antithrombotic therapies?
So generally, PFO closure should be accompanied with antithrombotic therapy. Most typically, patients are prescribed dual antiplatelet therapy from 1 to 6 months, and then single antiplatelet therapy indefinitely thereafter. In part, the antiplatelet therapy that's continued long-term is continued because the patient had an ischemic stroke and we're often never certain that it was the PFO. We're often somewhat confident, but never 100% certain that it was the PFO that caused the stroke. So we're also interested in potentially treating other forms of stroke as well.
What are the secondary prevention strategies that you would use for a person with PFO besides closure and antithrombotic therapies?
If we're confident that it was a paradoxical embolism, then closure is really the therapy that's recommended in combination with antithrombotic therapy. There have been trials with antiplatelet therapy and also with anticoagulation, and those may be effective, especially anticoagulation may be effective, but the evidence base really strongly supports the use of closure over medical therapy alone.
Why not just close a PFO in all patients who have an ischemic stroke and where you find a PFO?
Well, if PFO closure was completely without cost and completely innocuous, then that would be a good strategy to close every PFO that was discovered. But unfortunately, the procedure and the device are not without cost, and they're also not without adverse consequences. The most common adverse effect is atrial fibrillation, but there are other rarer effects of the procedure, such as bleeding, and of the device, such as infection or fracture. In addition, from the research that we've done, we understand that patients in whom the PFO is unlikely to be related to the stroke, for example, older patients with multiple vascular risk factors with a small PFO without an atrial septal aneurysm, that closing that PFO doesn't appear to provide any benefit in terms of reducing the risk of recurrent stroke. So you would be implanting a device in these patients, exposing them to the risks of the device and exposing them to the risks of the procedure without any potential for benefit. And it also needs to be said that the patients who are unlikely to benefit are also the ones who seem to be at the highest risk for the adverse events.
I'm Dr. David Simel, and I've been speaking with Dr. David Kent about PFO and stroke. You can find a link to the article in this episode's description. This episode was produced by Daniel Musisi at the JAMA Network. To follow this and other JAMA Network podcasts, please visit us online at jamanetworkaudio.com or search for JAMA Network wherever you get your podcasts. Thanks for listening.
This content is protected by copyright by the American Medical Association with all rights reserved, including those for text and data mining, AI training, and similar technologies.